We'll move on to our next talk. It's my pleasure to introduce Dr. Rachel Kruer, who is a clinical pharmacy specialist in the critical care unit at Indiana University Health Methodist Hospital, where she serves as the inpatient clinical pharmacy coordinator. She previously worked in the surgical intensive care unit with Dr. Hout at Johns Hopkins, and she'll be talking to us about DOACs today.
All right, good afternoon. Thanks very much for the invitation to be here today. I'm excited to talk with you a little bit about DOACs. Let me see. I have just one disclosure. I am a critical care content consultant for Wolters Kluwer. My objectives are really just going to be to review the data that exists for DOACs, which, spoiler alert, is not robust in trauma patients. We will talk about the safety and efficacy data in medical patients in the randomized control trials that have been published in that regard. We'll also talk a little bit about the use of DOACs for prophylaxis in patients who are status post elective orthopedic surgery, and then we'll talk a little bit about the retrospective data and some of the smaller studies that exist in trauma as well. So it wouldn't be a pharmacist presentation without a quintessential slide showing mechanism of action, so here we are. Basically, I'm going to focus this discussion on Rivaroxaban and Apixaban. These are the agents that are most commonly used in this space, and also there's the most data with Rivaroxaban and Apixaban. As you know, Rivaroxaban and Apixaban are inhibitors of factor 10A. They are highly selective agents. They are reversible inhibitors. They are not prodrugs, so they do not require biological activation. So we've established, I think, today that Enoxaparin is our workhorse agent here for VTE prophylaxis in trauma patients. So if we're going to compare our oral agents, let's compare them to the gold standard. So the bioavailability of Enoxaparin is outstanding at 100%. The onset of action is rapid. The half-life is short, but not too short, so that you're not committing to a long period of time of anticoagulation or prophylaxis, but you still don't require very frequent dosing. Metabolism is somewhat hepatic, and elimination is 40% renal. So if we're looking then at the DOACs in comparison to Enoxaparin, Rivaroxaban is 66% bioavailable without food, and the bioavailability increases with food, which I think is important, especially when we think about patients who are admitted to the hospital and may not be eating an adequate diet. The other thing that's important to consider here with Rivaroxaban, and something that I educate all of the residents that I work with on, is that if Rivaroxaban is delivered post-pylorically, the AUC and Cmax are both significantly reduced. So if you have a post-pyloric feeding tube, Rivaroxaban is not a drug that you want to choose. Apixaban has 50% bioavailability and is not as significantly impacted by the presence of food or by post-pyloric administration, so something to keep in mind. Rivaroxaban, as you know, is typically for prophylaxis once daily. Apixaban is twice daily dosing. The onset of action is very similar for both agents compared to Enoxaparin, fairly rapid at 2 to 4 hours. The half-life is a bit longer for our oral agents, but again, not significantly longer, impairing, so you're not overcommitting, is how I would say that, to an anticoagulant. Both have some hepatic metabolism, so there is some concern for drug interactions, but not a significant concern for drug interactions, in my opinion. Elimination is also somewhat renal for both Rivaroxaban and Apixaban. Of all three agents, Apixaban is the least likely to be affected by poor renal function, so that's something to consider as well. All right, now let's look at some outcomes in the data that we do have. So we'll start with thromboprophylaxis with DOACs in medically ill patients. And the two big randomized control trials that I wanted to talk about were the ADOPT and Magellan studies. So we'll start with the ADOPT trial, which was Apixaban versus Enoxaparin for thromboprophylaxis in medically ill patients. So this was Apixaban 2.5 milligrams twice a day for 30 days versus Enoxaparin 40 milligrams daily for 10 days, plus or minus 4, so 6 to 14 days. The primary efficacy outcome was any VTE or PE, and then death related to venous thromboembolism. And this was the primary efficacy outcome was evaluated at day 30. So this was about 4,500 patients. And among patients who could be evaluated, 2.7% in the apixaban group versus 3% in the enoxaparin group met the criteria for the primary efficacy outcome. However, when we looked at VTE and death related to VTE, so more significant, symptomatic VTE and death related to VTE, so this is the Kaplan-Meier curve on the left, figure 2, we see that the rates were actually not quite as high, about 1% in the enoxaparin group versus about 0.4, 0.5% in the apixaban group. And this was statistically different. This was not statistically different. However, when we look at the bleeding outcomes, there was a statistically significant difference with regard to bleeding, with bleeding being more common in the apixaban group. This is the Kaplan-Meier curve on the right. I'm sorry, let me go back. All right. The next study that I wanted to talk about briefly is the Magellan study. So this was Rivaroxaban for thromboprophylaxis in acutely medically ill patients. This is a similar study design, Rivaroxaban 10 milligrams daily versus Enoxaparin 40 milligrams daily. There was a non-inferiority evaluation at day 10 and a superiority evaluation at day 35. So this was, again, extended prophylaxis in the DOAC group. So the Enoxaparin was continued for 10 days versus the DOAC continued for approximately 35 days plus or minus 4. And you can see here that for the composite of the primary efficacy outcome for any DVT, symptomatic pulmonary embolism, or VTE-related death, that there was no difference between Rivaroxaban and Enoxaparin at the day 10 analysis, which met non-inferiority. And then looking at the day 35 analysis, again, there was a 4.4% of patients met the composite outcome for Rivaroxaban versus 5.7% in the Enoxaparin group, which met the superiority endpoint at day 35. When looking at bleeding, there was statistically significantly more bleeding in the Rivaroxaban group compared to the Enoxaparin group. So taken together for medically ill patients who received extended prophylaxis with a DOAC versus standard prophylaxis for about 10 days with Enoxaparin, we see that the DOAC is at least as effective and potentially more effective at preventing VTE, but that the rate of bleeding is higher than in patients who receive Enoxaparin. So if we switch gears then to thromboprophylaxis with DOACs in elective orthopedic surgery patients, the first study that I wanted to talk about was the Record 3 trial. So this is Rivaroxaban versus Enoxaparin for thromboprophylaxis after total knee arthroplasty. The primary efficacy outcome, again, was death, pulmonary embolism, or any DVT. Again, remember that because these are randomized controlled trials, ultrasonography was routine in these patients in both the previous trials and then again in these trials that we're going to talk about related to elective orthopedic surgery. So in these trials, the primary efficacy outcome was evaluated at about day 14 up until day 17 post-surgery. So for the primary efficacy outcome, there was no significant difference between Rivaroxaban and apixaban with regard to meeting the efficacy outcome. And when we look at the Record 3 trial with regard to the incidence of any bleeding in these patients, there was an increased risk of bleeding in patients. Look at this real quickly. It's really hard to see, and I'm sorry about that. So for the Record 3 trial, for the Record 3 trial, there is no statistically significant difference in bleeding, and hopefully you can see that. Go to Record 4. Okay, Similarly, Record 4 was similarly designed in that Rivaroxaban 10 milligrams daily was compared to Enoxaparin 30 milligrams twice daily. So this is the difference between the Record 3 study and the Record 4 study, is that there was a more intense low molecular weight heparin dosing strategy. So for the primary efficacy outcome, which again was any DVT, PE, or mortality at the pre-specified endpoint time of about 2 weeks, which again was evaluated up until day 17. We see that the primary outcome was observed in 6.7% of patients in the Rivaroxaban group versus 9.3% of patients in the Enoxaparin group, and this was statistically different. So because there was the difference, they did the investigators did do an additional modified intention to treat analysis on the primary efficacy outcome, and again maintained statistical significance when looking at the primary outcome. With major bleeding, you can see that the rates were very low, with 0.7% of patients in the Rivaroxaban group versus 0.3% of patients in the Enoxaparin group, and this was not different between the two groups. So then looking at extended prophylaxis in our patients who are post-hip arthroplasty, so shifting gears from total knee arthroplasty to total hip arthroplasty, this is a randomized control trial looking at extended prophylaxis with Rivaroxaban, and short-term prophylaxis with Enoxaparin. The primary efficacy outcome occurred, again, primary efficacy outcome for these studies is very similar, being any VTE event, symptomatic or non-symptomatic, and non-symptomatic being assessed with ultrasonography. We see that as well as death is a part of that composite endpoint. 2% of patients met that primary endpoint in the Rivaroxaban group versus 9.3% of patients in the Enoxaparin group, and this was statistically different. So extended prophylaxis did seem to be beneficial and perhaps superior than to the standard prophylaxis with Enoxaparin. We look at any on-treatment bleeding, which included on-treatment bleeding included 2 days post-study drug discontinuation. There was not a statistically significant difference between the extended prophylaxis group and the standard Enoxaparin group. Okay, so I did also want to include this meta-analysis that was published after these trials that included 8 randomized control trials of either total hip arthroplasty or total knee arthroplasty, looking at Rivaroxaban versus Enoxaparin for thromboprophylaxis. And Rivaroxaban was associated with significantly fewer VTE cases and all-cause mortality, as we saw in the previous studies. And there was a similar incidence of bleeding events, including major bleeding events, clinically relevant non-major bleeding events, and then also total bleeding events. So I did want to include guidelines that do mention DOACs, because we've talked a lot about guidelines today, and not all of the guidelines include DOACs because there hasn't been a lot of data. In fact, the CHEST guidelines published in 2012 recommended against the use of DOACs in surgical patients admitted to the hospital. The ASH guidelines do mention DOACs under the section of orthopedic surgery, and so in the section talking about total hip arthroplasty and total knee arthroplasty, the recommendation is aspirin or an anticoagulant, and when an anticoagulant is used, the suggestion is a DOAC over low molecular weight heparin. In all other cases, DOACs are not the recommended therapy. So that includes major general surgery, neurosurgical procedures, or major trauma. Okay, so then what data exists within our trauma patient population? So this is a study that was published in 2019 that was done by some of my colleagues at IU Health in Indianapolis. And this was a retrospective propensity score matched cohort study that included about 2,000 patients. And when comparing Rivaroxaban prophylaxis, again, the typical dose being 10 milligrams daily, to Enoxaparin, and our standard dose at this time was 30 milligrams twice a day, so the more intensive Enoxaparin dose. When evaluating any VTE after prophylaxis was started, the incidence was the same in both groups at 1.3%, no difference. When looking at any bleeding, again, the rates were relatively low at 0.8% versus 1.2%, and not statistically different. This is data that was published 2021, so again, pretty recent data that looked at DOACs versus low molecular weight heparin for thromboprophylaxis in trauma patients with lower extremity fractures, and this is TQIP data. And this was, again, a propensity score matched study. And when looking at the rate of VTE of any VTE, so pulmonary embolism or DVT, there was not a difference between groups. You'll see here that if you look at the actual numbers, it's 1.4 versus 0.4%. There was a published correction to this, and it's actually identical. It's actually 1.4 compared to 1.4%. So no difference in VTE, and again, no difference observed in major bleeding events. In this propensity score match study, the outcome for bleeding was actually a bleeding control surgery, and that was not different between the two groups. Okay, and then finally, the largest culmination of data that we have is a systematic review and meta-analysis looking at DOACs versus low molecular weight heparin for thromboprophylaxis after hip fracture surgery. And you can see in the random effects meta-analysis in the top figure there that there is some perceived benefit with the use of DOACs, but that confidence interval does cross 1, so not statistically different, but it does trend to favoring DOACs. And if you look at the bottom figure there, that's the fixed effects meta-analysis for both clinically relevant bleeding and what was classified as major bleeding, and there's no difference there between bleeding in patients who received a DOAC or low molecular weight heparin. So guidelines to reduce VTE in trauma patients. There is mention in the West decision algorithm of the use of DOACs, but it's restricted to patients who decline injection with enoxaparin. And really, this is just because I think we're lacking the data. We don't have robust, large, randomized control trials to really support a strong recommendation for the use of DOACs in this patient population. In my opinion, this is an area that's right for additional research. Okay, so key takeaways. DOACs appear to be equivalent to low molecular weight heparin with regard to VTE prevention in medical patients, and they also, however, are associated with an increased risk of bleeding in medical patients. In orthopedic surgery patients, so in the studies that we have for total knee and total hip arthroplasty, DOACs appear to be superior to low molecular weight heparin with regard to VTE prevention, even in the short term. So even when those studies evaluated the endpoint at 14 days. DOACs are associated with a similar risk of bleeding, seemingly, in these patient populations as well. We didn't see that increased risk of bleeding when we looked at the elective surgery patient population. In trauma, most of the data is retrospective. A lot of it is based on single center or database review. There is not prospective data in polytrauma or in patients with TBI. I think these are areas where we don't really know what the utility of a DOAC would be. And there is limited data that we reviewed in lower extremity fracture and fracture repair, suggesting similar safety and efficacy. Okay, so if I'm summarizing a list of pros for direct oral anticoagulants, it would certainly be the ease of administration. A lot of what Dr. Hout talked about with regard to patient refusal or nurses not wanting to give an injection potentially to wake up a patient and those kinds of things, some of those limitations can be minimized with the use of an oral agent. They do have quick onset, similar to enoxaparin. They have a short half-life, similar to enoxaparin. And there's no monitoring, at least we say that. And comparable efficacy, which I think is really important. Cons would be risk of bleeding. It doesn't seem that we have the same risk of bleeding in surgical patients, but the increased risk of bleeding in fairly uncomplicated medical patients, I think, is an area of concern, although that was associated with extended prophylaxis. So something to think about there. Reversal, in my opinion, is easier to give someone some protamine to reverse unfractionated heparin or low molecular weight heparin if you needed to, versus reversing a DOAC, which would require likely PCC, depending on what your formulary looks like at your institution. There's a lack of robust data. And then I think there's also the concerns related to enteral administration in patients that may have issues with enteral access, may have a post-pyloric feeding tube if Rivaroxaban is your go-to agent, or who have any issues with regard to absorption. Okay, with that, I would love to take any questions that you have.
Dr. Cordliffe.
Hi, that was great, Rachel. I had a question about the pharmacology related to the anti-inflammatory effects of heparin, and there's speculation and hypotheses, certainly in the COVID literature, that some of the difference in results between heparin and the direct inhibitors that have been seen are related to the anti-inflammatory effects, and should we be considering that in our patient populations that are probably pretty pro-inflammatory?
Yeah, I think that is a great question that you're asking, and I don't think we know the answer to that, but I mean, I think that's a really great hypothesis-generating question. Certainly, there is some hypothesis that certainly the heparins, actually, unfractionated heparin, and maybe low molecular weight heparin do have those same anti-inflammatory properties. We actually looked at this recently at my institution in COVID patients specifically, looking at heparins versus DOACs, and we didn't have, in patients with VTE who had COVID, and we didn't observe, we had a very small, unfortunately, patient population with DOACs, so it was hard to compare, but I do think it's a really great question and ripe for research as well.
Great stuff. Thanks so much. I had a specific question on a bunch of the studies you showed were, a month of a DOAC versus a short-term injectable, and then they showed one is better. I'm just curious what your opinion is on a study design like that. How do you tell the difference, the drug effect versus the...
Yeah. Good question. So what's the time effect of 10 days versus 30 days? And I think it goes back to the presentation that we heard earlier today about when those clots are likely to occur in the time frame post-injury or post-hospitalization. And I think that there's growing data and interest in extending DVT prophylaxis to prevent those clots. But when we saw those studies, those were the studies where there was increased risk of bleeding, were the studies where the DOAC was extended. So in those medical patient populations. So I think that's the balance that we're going to have to find. In the patients, in the elective hip and knee replacement patients, where the time point, where the endpoint for analysis was the same, about 2 weeks post-surgery, we didn't see those increased bleeding risks. We didn't see the increased risk of bleeding. So I think that that's a really good question, and I think it's going to be balancing risks. But I do think that with a study design that doesn't have an endpoint that stops at the same time, it will be really difficult to tease out where that risk benefit sort of breaks, if that makes sense.
Sorry, I have one more question. Who were those 1,000 trauma patients that got DOACs?
So that's a great question. From our institution, those are primarily isolated orthopedic trauma.
Okay.
Yeah. And that's, again, where most of the data lies in trauma, is with mostly isolated orthopedic trauma. Great question.
Great talk. Thank you very much.